Hello, dear doctors. I am Dr. Pradeep Gore, medical advisor from Sun Pharmaceuticals. Today, I take this privilege to welcome you all for the master's class on liver management options in diabetes and obesity. To present this interesting topic, we are privileged to have with us one of the eminent speakers in the field of surgery, Dr. Pradeep Chaudhary himself. Dr. Chaube is chairman of Max Institute of Minimal Access Metabolic Bariatric Surgery at Max Super Specialty Hospital in New Delhi. Dr. Chaube is one of the pioneers in the laparoscopic surgery in India and Asia Pacific subcontinent. He has worked with the singular determination to develop and propagate minimal access metabolic bariatric surgery in India. He has honorary surgeon to the President of India, honorary surgeon to Armed Forces Medical Services, and surgeon to His Holiness Dalai Lama. He has awarded Padma Shri by the President of India in 2002 for his dedication and services in the field of minimal access surgery. Dr. Chaube has served various associations as a president. He has been worldwide president of International Federation of Surgery for Obesity and Metabolic Disorders 2012-2013. Founder President of Asia Pacific Hernia Society in 2004. President of Asia Pacific Hernia Society in 2004 to 9. President of Asia Pacific Metabolic and Bariatric Surgery Society in 2010 to 2012. President of Asia Pacific Chapter of International Federation for Surgery of Obesity and Metabolic Disorders from 2011 to 2013. President of Obesity and Metabolic Surgery Society of India from 2006 to 2010. He has been the trustee and past president of Indian Association of Gastrointestinal Endosurgeons. Dr. Chaube is in association with his team and has performed more than 84,000 major laparoscopic procedures in the last 3 decades and has been featuring in the Limca Book of Records for 20 years consecutively from 2002 to 2019. Dr. Chaube is the editor for 10 textbooks and has more than 250 national and international publications to his credit. Teaching and training has been his passion and integral part of his career. He has begun conducting training workshops in 1990 and continues to train in all the minimal. Chaube is the personal attributes of sobriety, humbleness, kindness, and amity, coupled with his solid professional competence, mark him out as an extraordinary personality. I may now invite Dr. Pradeep Chaube to kindly take us through his presentation on the liver management options in the diabetes and obesity. Sir, I welcome you and I request you to kindly take over.
Yeah, thank you very much, Dr. Pradeep. You have given a very exhaustive introduction, and I am very humbled by your presentation, and thank you very much for giving me this opportunity today to be speaking to our friends and colleagues and participants about a very interesting and important subject, and also a subject which is very close to my heart. And fortunately, we have seen things changing for good in such a last at least 4 decades of my, more than 4 decades of my surgical career, and almost 3 decades in laparoscopic work. So I will share my screen in my first slide. Okay, so let's see now. Okay, so I bring greetings from our institute, Max Institute of Minimal Access Metabolic and Bariatric Surgery from New Delhi, India. And we are almost 32 persons working together for last 3 decades. Now, as we all know that we are talking about at the moment about the COVID pandemic, but now I think for a change we are talking about a global epidemic and moving on from epidemic to global pandemic, and now it is known as a globesity. So obesity now in many ways it's a globicity. It's a problem of each and every person. Just to recollect, in 2004, the world was divided into two parts. So we had 2.4 billion undernourished and 2.4 billion obese patients. Now, this is the situation which was there in 2004. Now, today we are talking about 2020. So obviously the obesity, the number of obese persons in the world are much, much more than the undernourished person. And that is quite a disturbing fact that every third person in the world is obese and having problems related with obesity. Now we talk about specifically about the Asia Pacific region. Now we have about 1/3 land mass. So about 30% world's land mass is with Asia Pacific region. But at the same time, we have got 60%. So it's almost the double. We have the 60% of the world's population lives in this Asia Pacific region. That means it's a very, very dense population. And of course, two major countries, China and India, contribute a lot of population to this 4 billion population of the country. Now, historically looking, I think, obesity was not that common. I think you will look at the first obese person on the record is Daniel Lambert. He's a 5 feet 1 inch, and he was 739 pounds of weight. And if you see, he was born in 1770 and we lost him in 1809. That means he's just about 39 years of age, he lost. And he was a goalkeeper of the Manchester Football Club. And why he was a goalkeeper? Because he was too big. So I think he could cover a little more space, but unfortunately, he could not continue with that. And he had to move back to his native place. And he was earning by the parents used to bring their children to show him. So he used to be in the tent and they used to pay a small few pennies and to show how the obesity looks like as you take your children to zoo, how the tiger looks like. So his source of earning was from, showing. People used to, and I'm sure there was no photograph or anything which they could take, but they just wanted to see. So that was a very unfortunate story. Now this is what we call is a Paleolithic representation of obesity. This is about 3,000-4,000 before Christ. So maybe, it's such an old this thing. And it was dug out in Austria. And, I always felt it as you all feel for Mona Lisa. So I think, I have been seeing for this this statue, and I always wondered that, like that obesity existed from time immemorial. So it means that even thousands and thousands years before Christ, obesity was, and this is a very specific thing. If you really look at the reproductive organs of this lady were more prominently displayed. I think it was denoting the importance of the females in producing and continuing the mankind and future. So this is this. But when I went to Austria for a obesity congress, I was very curious to go and see this statue because it has been seen over and over. And when I went to see the statue, this is the size of the statue. It is just about 2.5 centimeter or maybe 3 centimeter. I will not remember exactly. So, I'm standing in front of that statue. You can see, so it's the same thing happens when you go to see Mona Lisa and you expect it to be about 3 feet, 4 feet. Worldwide pictures are there. But when you go and see a very small portrait, you're always surprised. And that is what I think my surprise was at that time. Now here, I would like to emphasize the amount of money the world is spending. I think if you look at the money spent on obesity, management of obesity, the management of the complication, obesity comes at the third space. And what are the two? Smoking causes maximum economical burden, and social burden, the armed forces conflict, all the wars, and then comes obesity. So you can imagine that obesity is, it's a really something which is a huge social burden of human beings across the globe. And if you look at the economic impact, you will compare and you'll see that obesity, if we are talking about 2 trillion, armed conflict costs you 2.1 trillion, and smoking costs you 2.1 trillion. So that means we are almost at par with expenses and expenditure and economical damages which can be done by armed conflict. Now, today, modern society, I think, you see my picture with Walter Porras, and this is in 1995. And since then, Walter Porras is a physician, is a metabolic physician. And me being a surgeon, I think we have shared a lot of stages worldwide, and he would speak about metabolic syndrome, the medical management, and I will speak about the metabolic management surgically. So this is a lovely photograph. I have always cherished it, that both of us, we have worked on the medical as well as the surgical aspects, and we have very good rapport and relations. And what the concept which came was that rearrangement of the gastrointestinal anatomy. If you cut the stomach, connect the intestine, correct the small intestine, correct this, and so this is what the rearrangements, and you all need not go into the how we rearrange the intestine anatomy, but we never imagined that this realignment of intestine can reduce weight, not only reduce weight, but can resolve the problems of metabolic syndrome, hypertension, reduce the cholesterol. So everything changed. So this is a concept which was first time we all agreed on 2004, that diabetes is not a disease of pancreas, but diabetes is a disease related with the intestinal contents and intestinal anatomy, and how the intestine instructs and gives message to the pancreas for production of insulin. So now today, the biggest endocrine system is our gastrointestinal tract, not thyroid, not adrenal. Generally, when you talk about endocrine, thyroid, adrenal, etc., those things come in your mind. But the biggest endocrine organ today of the body is intestinal tract, because it produces number of chemicals and other things which are responsible for vital things like metabolism. Now, why it is so like in Asia? If you really see on the left side, you see a Western body. Western baby, when the baby is born, you see the fat content. The fat contents are smaller. If you see the Indian baby, the fat contents are much large. And Western body has got, a baby has got muscles more. And Indian and Asian population, when they are born, this is a newborn. So we are born with disadvantage. And that is more number of fat cells in our newborn baby as compared to the Western population and the Western newborn baby. And you have to put it in your, very strongly in your mind that this is the situation why we have more and more metabolic problem. Now, whether the more number of cells are there or our composition of fat cells are different, I think very difficult and more academic. This also a slide which I would like to emphasize, and these are all my message slides. The rest of the things which I will be talking will be more on the sort of figures and other things. But these are all my fundamental slides. What is a fundamental slide for Asia? It is just like a coin. Every coin has got two sides. So in Asian population, this is a coin. Obesity is on one side of the coin, and metabolic syndrome, and that is diabetes, dyslipidemia, and hypertension, is the other side of the coin. And what I mean by that is that if somebody has got obesity in Asia, 60-70% chances are that the person will have metabolic syndrome also. Invariably, all the obese person sooner or later will develop a metabolic syndrome. So that is one important message which I want to convey, that do not just think about kilograms of weight on the weighing scale, but it is the other side of the coin which is risky, which is life-threatening, and which ultimately causes all the problems of life, creates a very bad health and poor health. Now look at, this is very interesting slide. Just try to absorb this slide. China, obesity is 5%. India, obesity is 4%. But the metabolic syndrome is 26 and 20%. Whereas in USA, 1/3 of population, 34% are obesity, but still they have about 25%. You can see the difference. So that means that as an Asian, I think even at a smaller overweight or obesity, we are more prone for metabolic syndrome. So again, a very, very important message to be conveyed. Now, when we talk about obesity, we always talk about weight in kilograms, but I think obesity is one disease which practically gives rise, or maybe mother of all possible known diseases to the mankind. Common diseases, I would say, starting from osteoarthritis, heart disease, diabetes, sleep apnea, infertility, respiratory problems, gallbladder disease, increased chances of cancer. These obese patients have very high chances of uterine cancers, endometrial cancers, colonic cancers, gallbladder cancers, all renal diseases related with diabetes, hypertension, and high chances of stroke. And more than that, I think depression, anxiety, which is a psychological problem and psychiatric problem. So obesity is one factor which is responsible for practically all the common sufferings we all have. When we talk about diabetes, something which I have shown this slide, that we should consider about the liver also, the fatty liver. So you see the CT scan, and you can see the scan where it is laden with fat. So even if I'm sure a lot of your friends and colleagues will say when they get the ultrasound done, 20% of them will show fatty liver. That means our Asians, we have a tendency to deposit fat into the liver, and that is what causes NASH, what is non-alcoholic hepatic problems. So that ultimately leads to cirrhosis, like alcohol. So we feel that liver has got 2 or 3 major enemies. One, of course, is the viral infection. Second is, of course, the alcohol. But something which is not realized is the fat. Fat itself causes liver damage and ultimately leads to non-alcoholic cirrhosis and hepatitis. Now, this is a very confusing slide, and this is for your confusion. I will say that I'm just talking about the gastric bypass, sleeve, mini gastric bypass. These are the 3 operations you should look. Rest of the things are our academic thing, which a surgeon is supposed to know. First, talking about the gastric sleeve. Here, what you do is you staple and remove 80% of this. This portion of the stomach is removed, and you are left with a banana-shaped, stomach, so which has got a lesser capacity. So this is a reasonably popular operation done laparoscopically. Another is the gastric bypass. If you see that, what we do is we create a small space. The stomach is not removed. A small piece of the stomach is included, and these intestines, jejunum, goes there, and it sort of gets attached. So what happens? The food goes here. I think in the next you will see how the and So this is what, like this is what the animation which I use for explaining our patients how the food is going to behave. Another operation which is coming, I'm not very particular. See, I'm not very fond of gastric sleeve. I'm not very fond of this operation, which is known as the mini gastric bypass, because of the malnutrition which happens. So majority of the gastric bypass is the gold standard operation. So now coming to another thing, how does bariatric surgery resolve diabetes? It's a very important question. Is it just the weight loss, or if there is something else which we are not aware of? As you know, in my practice, what I have seen is that 1/3 of the patient after gastric bypass, they become non-diabetic from the next day. So they have not lost weight, but still they become non-diabetic, and all the requirements for diabetic medicines disappear. So then comes, there is point 2. Is there something else? Yes, I think there is something else which is not really very well understood by us, but I would like to simplify very in a simplifying manner. I would like to show you here. The improvement in the glucose metabolism. So what happens? The intestine sends signal to the pancreas for metabolism of the glucose through insulin. And after you bypass the stomach, and first the food goes into the very small pouch of the stomach and suddenly goes into the intestine, the signals which are sent to the pancreas, those are the signals which causes disappearance of diabetes. Now, simple diagram I will say. Now you see here the white points, which you see the white portion. These white structures are what we call is incretin. Again, this is a hormone which is produced in the first stomach and the first part of duodenum and jejunum, first part of jejunum. So you see this is up to first part of jejunum, and the black spot what you are seeing are anti-incretins, which are against this, like antigen and antibody. So white spots are friends of insulin, I would say. The black spots are enemies of insulin. And see the balance in a normal person, the incretin, these are the friendly portion of the protein, which is helping the insulin is more, and then the black portion. But in a diabetic patient, what we have seen, that black spots increases more. So anti-incretin are more in the first part of the stomach and stomach and the first part of jejunum and duodenum. So in diabetic patients, we have seen that the and if you look at the balance, so the enemy of the insulin is more. Obviously, insulin becomes less. And even if the pancreas is producing insulin, the body is not able to utilize that insulin. And this is what happens after the gastric bypass. So the food comes to the stomach and directly goes into the second and third part of distal part of jejunum. And the black spot, the enemies, they remain in the duodenum and first part of jejunum. And hence, they are not able to send the signal to the pancreas or antagonize the insulin. So this is a very simplified way, and this is known as proximal gut therapy. That means the first part of the gut, this behaves like that. Now there is some role of gut hormones, gut microflora, the bacteria, the other living things which are there. What they do is those bacteria flora we have seen and observed is different in obese persons. And they possibly harvest this, and they become the increased permeability of the intestine is increased, and more fat and nutrients can be absorbed and may produce this thing. But there are a lot of studies which are going on by changing the microflora of the intestine, the large intestine. So we remove the existing bacteria from the large intestine, and they replaced by different type of bacteria. And we are trying to see, some of the patients have shown good outcome. I'm not too sure what will be the future, but this is one of the new developments, as our topic today is the newer management options which are coming in. Now, this is very interesting study which we did. Started the study in 2006 and completed 10 years follow-up in 16. Now, what we did was we did a gastric bypass in a BMI 30 to 35 patients. And these are the things, HbA1c level, you can see the dramatic changes and the drop in HbA1c level. If you see this, starting point was there, and then, from 8.7, it has gone down to 6.2. That means it's a healthy, non-diabetic HbA1c. We have also seen the BMI. So BMI, we started, as I said, between 30 and 35. So on an average, it is 33, which has gone down to 23, which is a normal BMI, Same thing we have seen in blood pressure. Almost 60% of the patients, their blood pressure resolved after the gastric bypass from systolic. Have been seen in a younger patients. They found that the cholesterols were very high before operation, and it reduced dramatically there and that. HbA1c we have already compared, and this is our comparison of two other worldwide trials, Stampede trial and Cohen's trial, and our trial comes very close to their results. However, in Stampede trial, which was a Cleveland Clinic trial in US, you will see 42% endpoint, but they kept very low HbA1c. We kept HbA1c to 6.5, whereas they kept the HbA1c to 6. And that is what we feel, that if your HbA1c is less than 6.5, it's a very good outcome. Again, we have seen the hypertensive resolution, the cholesterol levels. And another question which comes to everybody's mind is the ROI, where, it's expensive surgery. But yes, I think, whatever money you spend, you save on so many diseases and so many complications. What we have calculated, and it has been published also on various journals, is also that whatever money you spend today, you get that money back in 2 to 4 years, and after that is all your benefit. So I think it's a fantastic, it makes a lot of economical sense to get operated. And this is the recent thing which you see last year. All the diabetic patients, I know it's a little, you may not be able to see it well, but I would like to point out to these two things which are encircled here. And it is the fact that if the diabetes is not under control and the person is obese, the right academic option for them is to go to bariatric surgery. And this is what it shows in the end of this thing. So now I'm just, skipping some of the slides. And those are slides more related to the surgeons. And I can discuss on each and every slide, but I would just quickly run over what are the new methods which are coming. None of them I will tell you before I present also, none of them they have worked. None of them they have worked, but when being used. So this is about in 2006, I implanted this gastric pacemaker sort of device in 2006. We did about 12 cases, and we thought that by stimulating the stomach and reducing the appetite, we will be able to gain something. Unfortunately, the initial results were very good, but ultimately we could not really manage, so it is all abandoned at that time. Gastric balloon, I'm sure you all talk about the gastric balloon. These are few gastric balloons, and these balloons are simple. What you do is they are filled with 300 to 400 cc of saline, and it occupies the stomach and reduces the appetite. But I'm not very much in favor, not good outcomes, because first of all, the patient is always full. It's very good, a very bad sensation. And then there is a nausea, then there is a vomiting. And after 6 to 8 months, you have to remove the balloon because they cannot lie permanently there. So not a good option. Another option which came a little modified, that you can, change the size of the balloon by remote control. You can increase or reduce the size. Again, it didn't work. Then where there was a very interesting device which came, full sense device, initially showed good results. It was a sort of mesh sort of thing which was implanted at the lower end of the esophagus and was covering the fundus. And it was assumed that if the fundus doesn't get, or the lower end of the esophagus doesn't get the message to the brain about the food, it may change. But again, it has not worked. I'm just skipping through that. Another very interesting thing came was a sort of polythene, or you can say synthetic sleeve, which was implanted endoscopically, and it used to be covering the duodenum and the first part of jejunum to see that the food does not come in contact with the duodenum and the first. So it was a separating film, but also it did not work because it has to be removed. And if you do the barium in these patients, you can see the barium is going into that sleeve inside, which is inside, and not allowing the food to be coming in contact. Keeping the same principle because it was a foreign body, another surgery was devised where by balloon and abrading sort of surfaces, we tried to ablate the mucosa of duodenum in the first part of jejunum. Again, it had a lot of complications and did not quite tedious procedure. Then comes something like a transoral gastroplasty. So you reduce the volume by stitching the stomach through the endoscope like this. So this way you are, endoscopically, you stitch and make the stomach size smaller, and smaller doesn't really work much. Then, there are a lot of over stitching has come. From inside, you make the stomach volume small. Nothing seems to be working. And I will not go into all these things there. Just to tell you that, like we operated, unfortunately, this 14 years boy, it created a world record and it was highlighted in front page of Times of India. This boy was almost 237 kg. When I saw him, it was 257 or 60 kg. We reduced it, and now I think the boy is we did the gastric bypass. This is the time when you can see, and this is the boy now have started going to school and lost about, and if you really Google Meher Jain, then you will find this all over the place, not in a good way. But yes, I think we feel a little satisfied that we could sort of salvage his life as a young boy. Now, what is important is that all these surgeries, all these things should be done in a center of excellence. And that will give you the standard outcomes, will provide a lot of safety to your patients. So you should not be, we always request our surgical colleagues that please do not casually do bariatric surgery or metabolic surgery. Just you have to be very serious about it. You have to have infrastructure. You have to have dedicated anesthetists. You have to have dedicated equipment, instruments to do and give a good outcome. Lots of newspaper and social media, the outcomes which you listen or see, those are outcomes which are not really from a very good center. Those are the outcomes from a smaller, less trained teams. Now you see, this is a patient. Now you will see that how things change with, we manage pain, we inject various painkillers, and these are the patients which can walk. Now you see this patient after operation, it's a dedicated anesthetic efforts, and this patient is, shifting himself from the operation table. And that is the beauty of the centers of excellence, everything, like the person is able to dial his telephone and meet the family within a couple of hours after the operation. And also they can really start walking, and that's the beauty of laparoscopic surgery. Also, coming to my final slide, I think this is the, we had the World Congress of Obesity, which we conducted in Delhi in 2012. And I requested His Holiness Dalai Lama to be our chief guest there. And this is the only piece of paper which Dalai Lama signed. If you see, his signature is here, which says that I pledge to fight against obesity, because Dalai Lama has not signed, does not believe in any fight. But when it came to fight against obesity, he gladly signed this document. And this is our treasure, that this is the only document in the world which is signed by His Holiness Dalai Lama. And we have a special privilege and honor to be there. So my conclusion is that bariatric surgery is the standard surgical option, which is not only suitable for weight loss, but it is also suitable for improvement of the metabolic syndrome and the related complications, including the psychosomatic, psychological, psychiatric complications, the problems which are there. And all over this world, I think it's no more a surgery which should be doubted, but I think this is a surgery which is a standard textbook problem. And the race is against time. I think, the sooner we get over all these things, the better it will be, because the only other way of losing weight is to stand on the two weighing machines, and your weight can easily be spontaneously be divided into half. And that is not, you will agree, is not the right way to do. My greetings from my department. I would love to answer any questions if you have, or any confusions which have arisen from this presentation. So I'm open for any discussion.
I would like to thank Dr. Chobe for his enlightening presentation. It is our great honor to have you with us, sir, for the question and answer session. The forum is now open for the questions. Already there have been a lot of questions. Sir, the first question for today's evening is coming from Dr. Ajit Singh Patna. It's very common question. What are the common complications of such surgical procedures?
Okay, so there are a couple of, I would say, common complication, but in a center of excellence with a trained team and good equipment, all the complications are less than 1%, less than 1%. And just to tell you that all these bariatric procedures are, according to our classification, are considered as high-risk procedures. So 1% is the complication rate in a good center, out of which 0.05% may be the chances of leaks wherever you have made the stapling and the thing, and maybe 0.5% is the bleed. And in a good center, these complications can be managed. The only one complication which we are really scared, and obese patients are prone, and that is the pulmonary embolism. But if the pulmonary embolism is managed by good physiotherapy and good counseling and a good nursing, I think, the battle is won. So in a good center, you prepare the patient well, you give them a physiotherapy of the chest, give them a lot of physical activities, and, you have to prepare the patient well, you have to operate the patient well, the anesthesia should be good, and you have to manage them post-operatively well. And it's a management throughout the life, you have to handhold them throughout the life, because whenever they have a problem, you should be there. So it's a very safe surgery, provided the one condition is followed, that they should be done by the experienced team in a center of excellence.
Center of excellence, right, sir. True, sir. Sir, again, the next very common question that is coming across all the surgeons and everyone is coming from Dr. Rajendra Singh Rathod from Busi. He is asking, on an average, with different procedures, how much of the weight loss is expected?
Well, I can tell you that any bariatric surgery should give you, on an average, 6 to 8 kilogram weight loss every month. Average I'm talking. So sometimes initially first 2-3 months we see a lot of weight loss, and next coming months we see the weight loss reducing. But on an average, this should be the weight loss. And we do not generally talk in kilograms, but we see that after a good operation done well and patient following it, the final BMI should be about 27.5 is our target BMI, which is a healthy BMI.
So target BMI is 30.
27.5.
27.5, right, sir, right. Sir, as this is a complicated surgery and frequent follow-up is also needed, so Dr. Harish Umrajkar from Pune is asking, what is the post-operative protocol in patients in terms of frequency to follow up, and what are the nutritional parameters are to be seen? and
So
other
I think,
requirements?
yeah, it's a very interesting question. And our protocol is fairly simple. We admit the patients for about 2 nights and 3 nights. They are walking around after 2 hours, 3 hours, and after the operation. And then, we put them on liquid diet for a day or two. And then, they gradually move on to semi-solids and the normal diet. Generally, we see them after 10 days or maybe a week or 10 days to look at the wounds. And then the patients go back with instructions and supplements. And first 6 months, we have some blood investigations, which they can get it done from wherever they come from. There are set protocols, there are groups, WhatsApp groups, support groups, which are available, so they can be in touch with them. And then every year they need a regular checkup, mostly to see vitamin B12 level and D3 level and protein levels, because that is what we would like to measure. But we have seen that if they follow, they take a supplement well, I think there's no really big follow-up. And in today modern world and all these Skype and Zoom and all these things, I think we should be able to manage people. We have got a lot of patients coming across the country, and SAARC countries and Western countries, African countries, and we are able to manage them through the video conferencing and support from the local doctors. Nothing really, it doesn't really need much close follow.
Right, sir. So the technology is solving the problems.
Yes.
Right. Sir, Dr. Chandrasekaran from Tanjore, he is asking about how to follow up late deficiency complications of bariatric surgery.
Well,
And what are the...
Yeah,
Yes.
micro deficiencies are very, very less seen. They take a supplement, very less seen magnesium and B6 deficiency. And those are the deficiency. What we do is every year when we get the checkup, we do a micronutrient assessment also. Zinc, magnesium, and vitamin B6. So that way we are able to pick them up, and managing them is not a problem at all. The commonest deficiency which we have seen is a B12 deficiency. But as you know, one injection of methicobal every month is good enough to keep the B12 level at optimal levels.
So as you are aware, we are in currently running the month of Ramadan. So that is a relevant question according to Dr. Nazirul Islam for Kalchibuja Barpeta. How to manage insulin dosing in this month?
This month, I think, is all to be graded according to sliding scale method. And also, I would tell you that please do not bother too much during this month. And I'm very practical in telling you, you cannot possibly monitor because your fasting and starvation is too high. And even if you have high blood sugar for a couple of days, it's not going to damage your kidneys or anything. But trying to manipulate, I think, first of all, it produces a lot of stress. You lose the fun of this thing. And I think, you can take liberty in having your blood sugar levels at a reasonable level. Don't change it too much. Just don't fine-tune the blood sugar.
Okay, sir. Got it. Not to very be careful, not to very fine-tune the sugars. Go as per the study. Sir, Dr. Mohan Patro from Vishakhapatnam is want to know, is endoscopic bariatric procedures are equivalent or equally effective as that of bariatric surgery?
No, not at all. I think, they have all very, very high recurrence. The endoscopic gastric plication, the results are not really academically, no. Value-wise, like balloon, there are a lot of people are going in for balloon, but, I have put 2 balloons 20 years back. And then after, I said never, So I'm not discouraging it. It's my personal view. First of all, it's a foreign body. And you know what, another thing which I have seen after 6 months or 8 months, when you remove the balloon, the quantity of their eating is very high because the stomach has stretched for, for 8 months to that level. The capacity So it goes against the bariatric principle that when you reduce the capacity of the stomach, whether you do a sleeve or a gastric bypass, mini gastric bypass, fundamentally you are reducing the volume. Here you are keeping the volume very high and keeping it occupied, and the patients are not very comfortable. Sometimes there is erosion, there is bleeding, and sometimes the patient do not tolerate. We have to remove the. So I see the results, and ultimately they lose 5, 6, 7, 8 kg in 6 months, 8 months time, and they regain much more than that after the balloon is removed.
Right, so thank you so much for that answer. Sir, Dr. J. Muthukumaran from Thiruvar is asking how to reduce central obesity in elderly patients who are having hypertension, diabetes mellitus by non-surgical methods.
Well, I think then we should not be looking at a very ideal situation. What I suggest is that you can put them on meal replacement, and no hesitation in telling you that Nestle has got a very good product, which is Optifast. Optifast is a very good product. You can very safely replace one of their meals. So that, it's a very balanced, it gives you 20 grams of protein. So the protein deficiency is not there. And at least they can easily lose a couple of kilograms of weight. At least they will be better off. And the first weight loss will take place from the liver, which is important for us. And their diabetes, etc., will also improve over a period of time. They will never go into, so one meal replacement by Optifast or maybe equivalent product is good enough.
Right. Sir, this question is very interesting. How to differentiate between pre-diabetes and the person who is new onset type 2 diabetes?
I think the important thing will be the BMI. What is the BMI? So we'll be able to, then we can do a tolerance test, or we can give you a stimulation test. There are a couple of tests which are there for diagnosis. But to me, most of these tests look more to come to that. If you are able to, if those patients are obese, then I think if they reduce weight, I mean, why you do all these tests? You reduce the weight, I think whatever it is, it's likely to disappear.
Right. Sir, we have a question right from Siliguri, Jalpaguri, from Dr. Subrata Roy. He's asking, is gastric banding still practiced?
No. Gastric banding 20 years back we started, and first of all, it's a foreign body. It needs adjustment off and on, and there were revision. I think our revision rate went to more than 50%, Then ultimately, almost whatever bands we might have put, or there are so many bands put in the world, most of the bands are out now. Either there is a infection of the port, or there is a band gets eroded into the stomach. So practically that was initially. I don't think practically it's out of this thing.
Sir, this is question related to very common complication, that is microvascular complications. When, at what time to get this complication, and if properly treated, how to prevent them?
Well, microvascular complications are the results of uncontrolled diabetes. So if the patients have got uncontrolled diabetes, then we are likely to get that sort of complications. And we always suggest that if the HbA1c is not controlled and the person is obese and morbidly obese, instead of waiting for them to resolve on their own, it's always better to put them and get them a bariatric surgery done before they get complications, So otherwise, what happens, the beta cells also of the pancreas, they get exhausted. So the beta mass reduces over a period of time.
Yes.
After that, the surgery may not bring as wonderful results as it is. Generally, we have seen if the duration of diabetes is more than 10 years, then the success rate goes down. And by the time renal damage, albuminuria, raised creatinine, etc., this all comes, which is not really right thing to do.
Yes, sir. Most of the questions you have already answered in your presentation, sir. This is the last question that we are taking. What are the indications for insulin in type 2 diabetes?
Well, I think it's better advised by the endocrinologist.
Yes, sir.
We have got our metabolic physicians which decide. So I will not be very precise when the insulin should be started, but when you see that the HbA1c is not getting under control, I think that will be a reasonably good time to move on to insulin, because by far insulin gives the best management of diabetes, most accurate, and also prevents the microvascular complications of diabetes. But at the same time, I would like to add that insulin treatment increases the weight of the patient, right? So, like the BMI will become more after starting the insulin therapy.
Right, sir. Thank you. Thank you so much for the answers. Thank you so much for the presentation. I now request Mr. Kunal Banodkar, BU Head Classic Team of Sun Pharmaceuticals, to kindly deliver us the vote of thanks. Kunal sir, over to you, please, sir.
Thank you, Dr. Pradeep, also for being there and conducting it from the medical point of view. It makes my job very simple. And thanks for your help in this presentation. Yes, Kunal.
Yeah, thank you, sir. We from Sun Pharma, thank you, Dr. Pradeep Chobe, for your valuable insights on newer management options.
Sir, speak loudly, speak loudly.
We from Sun Pharma, thank you, Dr. Pradeep Chobe, for your valuable insights on newer management options in diabetes and obesity. I'm sure your talk today will bring a significant change in management of diabetes and obesity in India. We thank all the delegates for taking out the time from busy schedule across India for today's master classes. We at Sun Pharma will continue to do such scientific programs in future as well. So with this, take care, stay safe, and thank you from my end.
Thank you, everybody. Thank you, all of you. Hope to see you soon sometime.
Thank you again, sir. Thank you so much.
Yeah. Okay.
Good day, sir.
Good day.